This slide's presentation will focus on selecting interventions for the hemiplegic upper extremity. And the information is actually adapted from the Wolf et al. Article that was published in 2016. This algorithm that we're going to go through is based on what's known as the SAFE model. SA is shoulder abduction, and the FE of SAFE stands for finger extension. The algorithm itself starts on the next slide, and I've chosen to simplify it by creating links to the next step in the algorithm, depending on whether the answer to the question is yes or no. And once you go to that next slide, by clicking yes or no to get back to just click on the picture. So the first question is, can the patient produce any voluntary muscle activity in the affected upper limb? Okay, this is a person who's 0 out of 5 strength in their hemiplegic upper extremity. So let's say that no, this person cannot produce any voluntary motion. According to the algorithm, these are appropriate interventions for the patient. Very important, you want to assess and treat hand edema. Okay, you don't want any swelling in the hand, and sometimes this can progress to complex regional pain syndrome, which we'll talk about later on in the spring. If the person can't move at all, you want to make sure that you provide passive range of motion to maintain joint mobility. You can provide this PROM by yourself, or you can instruct the patient in providing passive range of motion to their affected extremity independently. You might want to also consider the use of supportive devices. Examples of supportive devices would be different kinds of shoulder slings, and this is going to prevent a shoulder subluxation. You may also consider a wheelchair arm trough that's going to help the patient maintain joint approximation in their shoulder joint. Always important for all stroke patients is going to be patient education. Education on the use of doing as much as they possibly can with their hand, and making sure that they can pay attention to their hand, especially if they have neglect, and they might have some sensory issues. So that's another thing to educate your patient on. Next, you can use motor imagery. Okay, motor imagery is just positive mental imagery is another way to say the same thing. And this is where the patient is in a relaxed position, and they're imagining using their affected arm to do activities like they were before the stroke. Another important area that you can work with is called sensory retraining. And essentially, you're going to use sensory modalities to help stimulate motor function in the affected upper extremity. In the spring semester, again, we're going to have a talk on sensory retraining by one of the groups. Always things that you can do to help stimulate muscle activity is going to be just simple weight bearing. Weight bearing through the hand, you might have to support the triceps tendon just a little bit to maintain that elbow in some extension. Okay, but weight bearing itself is going to help approximate that shoulder joint. Always a possibility. You can use E-stim. If somebody doesn't have anything at all, it's probably the best idea to start at the shoulder to make sure that you can prevent shoulder subluxation. E-stim for the shoulder is going to be a simple thing that you can work on with this patient, especially during functional activities. Mirror therapy, you can see in the picture on the right-hand side of the slide. This is a woman who's using mirror therapy, and essentially you set up a mirror and you put your affected hand facing the mirror, and or your unaffected hand facing the mirror. And when you look in the mirror and you move your affected hand, it looks like your unaffected hand is moving also. Most importantly, avoid splinting. Do not put the patient in a position of flexion and internal rotation. This is not going to help them at all. You want to encourage the use of that hand as much as possible. Okay, so let's say you're working with a patient who does have some voluntary muscle activity in the affected upper limb. The answer to the question would be yes. The next question then is, in the seated position, can the patient produce any shoulder abduction against gravity? Okay, they can move something. There's something more than zero happening somewhere in the arm. But if that person can't produce any shoulder abduction against gravity, let's say no. And again, these are the appropriate interventions. I've chosen to highlight everything in green that we've talked about previously, and anything new is going to be down here in yellow. So new, if the person has shoulder abduction against gravity, you can provide active assistive range of motion, and that's where you're helping as a therapist and allowing the patient to do as much for themselves as possible, or you can have the patient, you can educate the patient on how to perform active assistive range of motion themselves with using their unaffected upper extremity. Okay, another kind of active assistive range of motion could be robot-assisted therapy. And again, this wouldn't be passive range of motion. It's where the robot is providing appropriate assistance to allow the patient to use their arm in functional situations. Question 2. Now, in the seated position, can the patient produce any shoulder abduction against gravity? If the answer is yes, then you go to question number 3. And the last thing is, with the forearm prone on the table and the hand and fingers unsupported, can the patient initiate finger and or thumb extension 3 times within a minute? Okay, if they can't do this, then these are the appropriate interventions that are recommended. Again, all the ones that are here in green are things that we've talked about previously. But now, since the person has pretty good arm function and but not the best finger extension, they're going to recommend strength training, any kind of task-specific training. Bilateral arm training is what you see here with this patient in the figure on the right-hand side of the slide. She's using her affected and unaffected hand to perform a task bilaterally. It doesn't necessarily have to be a task. It can just be a motion. Okay, but bilateral arm training is a special kind of therapy that, again, I'd like to have somebody talk about coming this spring. In addition to this, you can start to incorporate video games, any kind of video gaming where the person is using both hands or just their affected hand. Question 3, the person now has finger and thumb extension 3 times within a minute. If they do, then appropriate interventions are going to be, again, motor imagery, sensory training, strength training, task-specific training we've already covered. A new one here is CIMT, and CIMT stands for Constraint-Induced Movement Therapy. Okay, the constraint-induced movement therapy is going to be a very specific technique. There's lots of different kinds. There's modified, and then there's straight up constraint-induced movement therapy. Essentially, what it is constraining the unaffected arm, typically in something like an oven mitt, and putting it in a sling and forcing that person to do all of their activities with their affected arm. Okay, if they have that finger extension, they should be able to do that. And this is found to be very effective for recovery of upper extremity following stroke. And again, I'd like to have a group talk about that coming in the spring.